a minute just to get. Thank you so much, everyone, for tuning in. We're just going to give it maybe like 30 more seconds just to allow a few more people to join us, and then we'll get going. All right, well, welcome everybody to the Leukemia and Lymphoma Society of Canada's webcast, Managing Myeloma, Diagnostic, Treatments, and Side Effects. Today, Dr. Anthony Reiman, medical oncologist at the St. John Regional Hospital, will provide an overview and answer your questions about myeloma. To begin, let me introduce myself. My name is Charlotte Hall-Coates, and I'm the Community Services Lead in the Atlantic region with the Leukemia and Lymphoma Society of Canada. I will be the host of this online event. Since there are many of you, we invite you to type your questions and comments into the Q&A box located on your Zoom panel throughout the presentation. An LLC staff member will monitor the questions, and I will read some of your questions aloud at the end of the presentation during the question and answer period. Due to the large number of participants and limited time, we may not get to all of the questions. Also note that our speaker cannot answer any specific questions about a person's health status or history. Therefore, case-specific questions will not be read aloud. If we do not get to your question during the live presentation, a community services lead will contact you after the webcast. Today's presentation is being recorded, therefore you can watch it again on our website. Before we begin the main presentation, I would like to share with you our mission and highlight some resources that may be helpful for you or someone you know. Next slide, please. Leukemia and Lymphoma Society of Canada, our mission is to cure blood cancers and improve the quality of life of those touched by a blood cancer and their families. We are here for you, whether that's listening with compassion to the challenges you are facing, helping get you the information that you need, and helping you get organized to manage and take charge of your care. We are here for you every step of the way. Do not hesitate to contact the community services lead in your area. Next slide, please. Our website, bloodcancers.ca, was designed with you in mind to ensure easy and personalized navigation no matter your current situation. Next slide, please. On our website, you will find fact sheets and booklets, animated educational videos, webcast recordings, podcasts, and much more. Visit www.bloodcancers.ca to access these tools. Next slide. Another resource that can help you is the LLS Health Manager app. This free app can help you track side effects, medication, food, and also includes a hydration journal. The app also features medication reminders and has a nutrition meal planner along with many recipes to help you get the nutrition you need. The app is available for caregivers and is free to download in the App Store on Apple or Android devices. Next slide, please. Our peer support program is a support service that matches people affected by blood cancer, caregivers and their families with trained volunteers who have been touched firsthand by a blood cancer and have shared similar experiences. Whenever possible, participants and volunteers are matched based on their age, gender, and diagnosis or the issue that is most concerning to them. Contact the community services lead in your region to learn more. Next slide. All right, so it is now my pleasure to introduce today's speaker, Dr. Anthony Reiman. Dr. Reiman is a medical oncologist at the St. John Regional Hospital in St. John, New Brunswick. He is the Canadian Cancer Society Research Chair at the University of New Brunswick and a professor in the Department of Medicine at Dalhousie University. Dr. Reiman co-chairs the Hematology Disease Site of the Canadian Cancer Trials Group and is a member of the Canadian Myeloma Research Group, the U.S. National Cancer Institute Myeloma Steering Committee, and the International Myeloma Working Group. His clinical practice and research focuses heavily on multiple myeloma. Thank you, Dr. Reiman, for being with us here today.
Thank you, Charlotte. I appreciate the introduction, and welcome everyone to this webinar. I hope that you find it useful. I'm going to be really speaking to people as though perhaps there are people in the audience who really don't know much about what cancer is or have a great understanding of exactly what myeloma is, although you may be affected by it. So for some of you, maybe some of the information will be things you already know, but hopefully everybody will pick up something. So I'm going to start by trying to explain what multiple myeloma is, and it helps understand what a cell is when we're talking about what multiple myeloma is. So our bodies are built out of cells. Those are the building blocks of our bodies. I guess you could say it's the smallest unit of life. These are small structures, about 10,000 of them can fit on the head of a pin. And our bodies develop from a single cell, a fertilized egg, into trillions of cells in our fully grown adult bodies. And there are different kinds of cells throughout our body to produce our skin and our heart and our lungs and our liver, all of our different organs and tissues. So this cartoon just shows a cell with a nucleus that has the genetic material contained within it in orange, and then the rest of the cell in blue. So that's a cartoon of what cells look like under the microscope. So it helps then, knowing what a cell is, to understand what cancer is. So cancer develops when one of our cells, one of our trillions of cells in our body, turns into a cancer cell. It was a healthy cell, something's happened to it, perhaps a few different types of damage have happened to the cell, and it turns into a cancer cell. Usually this is through damaging the genetic material of the cell, the DNA of the cell. So in this cartoon, you can see a cell that's normal that has sustained some DNA damage, so some sort of mutation of the cell's genetic material. And this happens all the time, but sometimes the damage to the genes of a cell can turn into a cancer cell. And so then we have to understand, well, what makes a cell a cancer cell? This little cartoon is showing a cell that can't repair the damage and a cell that's multiplying, so that now we have multiple cancer cells that have arisen from a single cell. And if you get enough cancer cells, you need 10,000 of them to fit on the head of a pin, but if you get enough of them, they can grow into a tumor. So this is a mass of cancer cells in the body, and this slide just shows a CT scan of a patient with multiple myeloma who's got a tumor in the hip on the right side here, this roundish gray structure circled in red, getting into the hip joint, the ball and socket joint of the hip there. And if you take a biopsy of that tumor and look at it under the microscope, you will see cancer cells under the microscope, which is what's shown on the left-hand panel. So that is one of the hallmarks of cancer, is a cell with damaged DNA that is multiplying and developing into a tumor. The other main hallmark of cancer, aside from the ability to grow in an unchecked fashion into a tumor, is that cancer cells can spread through the body. So in the cartoon on the left, you can see near the top blue cancer cells, a cluster of cells within a tumor. What they're trying to show here is cells getting out of the tumor and into a blood vessel, where they can then circulate through the body and then exit the blood vessel at a second site in the body, distant from the tumor where it originated, and then enter a different organ or tissue in the body at some distance from the tumor where the cell originated. That secondary tissue can then develop a tumor within it as that cancer cell multiplies and grows into a tumor. The panel on the right shows a CT scan of the spine of a patient with multiple myeloma, and maybe it's hard to appreciate unless you looked at a lot of normal CT scans, but this spine is riddled with little holes. It looks like it's just full of little holes, and what you're seeing there is holes that have been eaten in the bone of the spine by tumors, multiple little tumors within the spine. And that's where the idea of multiple myeloma comes from, is that you get so many tumors throughout, typically the bones. So that's what cancer is. Multiple myeloma is a type of cancer. It's a cancer of a type of cell known as a plasma cell. And this is a picture that just shows what plasma cells look like under the microscope after you stain them with some dye to highlight them. These purple structures, purplish blue structures, are cancer cells. The dark purple bit in the middle is the nucleus of the cell that contains the genetic material, and the rest of the cell is this lighter blue purple color around it. They look kind of like fried eggs. Those are plasma cells of multiple myeloma. So these cells are typically found inside the bones, in the bone marrow. And so this is a cartoon of a bone showing the inside of the bone. If you take this close up in the middle panel on the cartoon on the right, the outer part of the bone is the hard shell, the so-called compact bone, or the cortex of the bone. And then within the bone, there is more spongy bone that contains marrow within it. And that's where you typically find multiple myeloma. The bone marrow is normally where your blood is made. So there are cells in the bone marrow called blood stem cells that have the ability to develop into different types of blood cells that are found circulating in your bloodstream, including red blood cells that carry oxygen from your lungs to your tissues, white blood cells of different sorts that help fight infection, and platelets, which are little fragments of cells that can help stop bleeding in the event of a cut or an injury of some kind. So that's what's normally found in the bone marrow. But in the case of multiple myeloma, instead of seeing lots of different kinds of blood cells being made, you see significant areas of the bone marrow that are replaced by the myeloma plasma cells. So sometimes these myeloma cells can get out of the bone marrow and invade into that hard outer shell of the bone that gives the bone its structure. And that's where you see those holes in the bone, like we saw on that CT scan here. You can see all those little holes. And that's what makes the bones more fragile in some patients with multiple myeloma, is that these plasma cells get into the hard structural shell of the bone and disrupt its integrity. You can sometimes find myeloma cells outside of the bones altogether. So sometimes you'll see them circulating in the bloodstream. If you take a blood sample and have it looked at under the microscope in the hospital laboratory, sometimes that's seen. Sometimes it's called plasma cell leukemia if you see enough myeloma plasma cells in the blood. But that's a variation of the disease known as multiple myeloma. You can sometimes see tumors developing in tissues outside of the bones in other organs of the body, the liver or the lungs, for example. That doesn't always happen, but it happens sometimes, especially as the disease progresses. So plasma cells, there are normal plasma cells in the body, and so myeloma is a cancer of plasma cells, where plasma cells have developed DNA damage and have acquired the property of being cancer, being able to grow into tumors and to spread through the body. But normal plasma cells exist in healthy individuals and in people with myeloma. And they are part of a healthy immune system. And those plasma cells produce proteins called antibodies, sometimes called immunoglobulins. And these antibody proteins can be produced by these cells and can be found circulating in the bloodstream. And our body normally has the ability to generate billions or even trillions of different kinds of antibody proteins. And their role is to help fight off different types of infection. There are other roles for the immune system, but that's a straightforward way of looking at it. That healthy plasma cells produce antibodies to help fight infection. But antibody proteins produced by myeloma cells are not serving any useful purpose for our body. And because these plasma cells are all copies of one another and they all have similar genetics within them, they all produce the same antibody. So instead of producing billions of different kinds of antibodies that can fight off different kinds of infections, all the myeloma cells are just producing one antibody. And we call this a monoclonal antibody or a monoclonal protein, or an M protein for short. So I'll show you how we can detect this and measure this in the blood in a moment. And this can serve a useful purpose for people with myeloma because it's a marker of the disease. So the classic blood test for looking for this monoclonal protein in the blood, this myeloma protein, this monoclonal antibody, the test is called a serum protein electrophoresis. And what happens is people take the serum out of your blood in the hospital laboratory by spinning the blood in a centrifuge to separate the serum from the rest of the blood, and then put that serum onto a gel in the lab, and then apply an electric current to that gel. And with that, the proteins in the gel migrate and separate according to their size and their electrical charge. This is a depiction of a normal looking result on a serum protein electrophoresis, or SPEP. You see a peak if you plot the intensity of the proteins across the gel. You see a peak on one end representing the most abundant normal serum protein, which is called albumin. And then you see different bumps or peaks across the graph, indicating where different size proteins found in the blood migrate along this gel and under the influence of this electrical current. And these regions are named with Greek letters: alpha, alpha 1, alpha 2, beta, and gamma, as you go across the gel. Normal antibodies are typically found at the opposite end of the gel from albumin in this gamma region. And myeloma proteins are also found there. If you look at the blood of a patient with myeloma, you'll see something quite different. You'll see a spike at the opposite end of the gel from albumin in the gamma region. And that represents the accumulation of this myeloma monoclonal protein, or M protein, in the blood that's being produced by the cancer cells. And that's where this term monoclonal gammopathy comes from. Gammopathy takes the Greek letter gamma because that's the part of this gel that you find in the protein. It's the gamma region of the electrophoresis. So it's a rather jargony way of referring to this. But when you hear the term monoclonal gammopathy, that gives you some idea where the term comes from. But this is just a way to detect myeloma protein. There are other blood tests that are frequently used to measure myeloma or monoclonal protein. There's a test called quantitative immunoglobulins, which is another way of trying to measure the levels of different types of antibodies in the blood. Sometimes if it's hard to measure the M protein on the electrophoresis, this immunoglobulin test can be used as a surrogate or a substitute way to try to measure the protein. These proteins are composed of different subunits or different chains of protein. There are heavy chains and light chains that are attached together to make these antibody proteins. Sometimes you can find the light chains floating in the blood unattached to the heavy chains. And so we can measure those with a test called the serum-free light chains. There are newer methods of measuring these M proteins in the blood that use newer techniques. Something called mass spectrometry is one method. And this is maybe a more sensitive way of detecting small amounts of myeloma protein in the blood that sometimes you'll see being used. We can also look for these proteins spilling from the bloodstream and through the kidneys and into the urine. So sometimes you can detect myeloma proteins in the urine, especially those light chains, because they're smaller proteins that can get through the filtering system of the kidney and into the urine. And sometimes that urine monoclonal protein is known as Bence-Jones protein, named after some of the people who sort of described these proteins in the first place. So measuring these myeloma or monoclonal protein levels is important. First of all, because this can be a clue to the diagnosis of myeloma, to find this protein in the blood or the urine. And also for someone who's known to have myeloma, if the level of protein is increasing, it would suggest that the myeloma is growing and progressing, that those plasma cells are replicating and expanding in number. And so there's more myeloma in your body now than there was before. And that can be indicated if the protein level in your blood is going up, the monoclonal protein level. On the other hand, if you're getting some treatment for your myeloma and the protein level is going down, that's a good sign that the treatment's effective in treating the myeloma, and so there's less myeloma producing less of this protein in your blood than there was before. You have to kind of know what is a significant increase or decrease in the levels, and it's normal to see some day-to-day or month-to-month small fluctuations in the level of protein in your blood, even if your myeloma really is not progressing or responding to treatment. If it's staying the same, there can be just some small variations in the measured levels of protein in the blood. So, your doctor can help you interpret your test results in that regard. So that's a brief explanation about what multiple myeloma is. It's this cancer of bone marrow plasma cells producing this monoclonal protein. But how does that affect a person? If you have myeloma, what happens? I mean, some of you could tell me what's happened to you, but in general, we can use this acronym CRAB, C-R-A-B, and we teach this to medical students, and medical residents, to help them remember some of the key features of myeloma that patients present with. And the C in CRAB stands for calcium. So calcium can sort of be leached out of your bones and into your bloodstream, and the blood levels of calcium can increase as a result of having multiple myeloma. And this happens with other kinds of cancer too, not just myeloma. But this can sometimes happen. And this can make a person unwell. If your blood calcium level is too high, it might make you feel drowsy or disoriented or confused. It might cause constipation. It might cause you to become dehydrated because your kidneys are trying to get rid of this extra calcium in your blood and drawing water out into the urine with the calcium. So these are some of the things that can happen if your calcium level is increased, and we can treat the calcium level and bring the level down to relieve those problems. R stands for renal, which is another word for kidney issues. And so this indicates that myeloma can cause kidney damage. And this is typically caused by those light chain components of the monoclonal protein. Those can get into the kidneys and kind of gum them up and cause kidney damage. And we can detect this on your blood work. We can look at blood tests to look at how well the kidneys are working. And we'll come back to that in a minute. So that's often how we figure that out. If the kidneys are severely damaged, you can start to feel unwell from the kidney damage. A stands for anemia, which means low red blood cell levels. But in general, we can think about all the different kinds of blood cells and how those are normally made in your bone marrow. And if you have a lot of myeloma cells in your bone marrow, those can crowd out, kind of elbow out the healthy bone marrow cells that are making your blood and impair your body's ability to make blood. So your blood cell counts can be low. And so that's the A for anemia. B stands for bone. So those tumors in the bones, fragile bones that can be prone to breaking. The bones can just get thin, even if it's not because there's tumors in them. The myeloma cells talk to the bone cells and sometimes cause the bones to become thin. This X-ray on the right is a skull of a person with myeloma. And again, there's lots of little holes, many holes in the X-ray, which represents bone that's being degraded by tumors in those areas. So that's the CRAB acronym to remember some of the key problems that myeloma causes for people. Other blood tests that we do when thinking about myeloma, a complete blood count, or a CBC. This is essentially counting the different types of blood cells. And this can be done by looking under a microscope, or nowadays a machine automatically can count blood cells. And there's lots of measurements listed on a CBC result. So if you're getting your blood test results and you see, 20 different, numbers on your CBC test result, it helps to know which ones to focus on. And maybe you can focus on just 2 or 3, maybe 4 of them. Hemoglobin is a protein that's found inside red blood cells and carries oxygen. And we can measure the amount of hemoglobin in the blood as a measure of the abundance of red blood cells. So that's a number that we often talk about, the hemoglobin level. These things are typically expressed in terms of the number of hemoglobin molecules, or the mass of hemoglobin molecules per milliliter of blood. We can talk about counting cells. We can talk about the number of white blood cells, say per milliliter or microliter of blood. We can talk about different types of white blood cells that we look for in the blood. That's called the differential, looking at the different types of white blood cells. It's helpful to look at the neutrophil count, especially in people receiving treatment for their myeloma. White blood cells, you might remember, help fight infection, and neutrophils are a type of white blood cell that are particularly sensitive to some of the drug treatments we use for myeloma. The lower your neutrophil count is and the longer it stays at that low level, the more susceptible one is to infection. So we monitor that and sometimes take steps to remedy a low neutrophil count if necessary. And then the platelet count to look for those little particles in the blood that can help with blood clotting. Make sure the platelet count isn't too low as a result of the myeloma or the treatment, so that you're not at undue risk of bleeding or bruising issues. Aside from looking at blood counts, we look at other things with what we call chemistry lab test results. Creatinine is the blood test that we usually rely on primarily to assess how well the kidneys are working. What we're looking at is how well the kidneys are filtering the blood with this test. Normally, creatinine is a substance that's a breakdown product of our metabolism, and it's normally gotten rid of through our kidneys and into our urine. If the kidneys are not doing their job to filter the blood well, then creatinine and other substances can accumulate in the blood. And so the more creatinine there is in the blood, the less well the kidneys are doing this job of filtering the blood. So higher creatinine means more kidney dysfunction or a deterioration in kidney function. If the creatinine is going up, that's not what you want. You want it to be down in the normal range. We mentioned the calcium level. We'll also monitor people's other electrolyte levels, things like sodium, potassium, magnesium levels. These can be affected by myeloma and its treatment and sometimes require correction. Sometimes we'll give people potassium or magnesium supplements, for example. We'll monitor the liver with blood tests, not because the liver is commonly affected by myeloma, although it is occasionally, but more because we just want to make sure that the liver is working well as we rely on it to get rid of some of the drug treatments that we give for myeloma from the body to break down those drugs and help clear them from the body afterwards. And if the liver is not working well, then we have to adjust the treatment to avoid accumulation of these drugs in the system that can cause more side effects. So we monitor that. And sometimes we need to look at blood clotting tests. So the INR and the PTT are measures of blood clotting ability, and sometimes we have to prescribe blood thinners to patients with myeloma, and sometimes we'll use these tests to monitor the effectiveness of those blood thinners. So those are some other commonly used blood tests that you may see being done in your case. Aside from blood tests, when we're investigating a patient with multiple myeloma, we'll often do some diagnostic imaging tests. So this is a way to take pictures of your insides, essentially, typically focusing on the bones, but sometimes other areas. And this helps us to understand how much the bone is being affected by myeloma, to define where we might see myeloma tumors in the body. And sometimes we can get an assessment of this just with plain x-rays. You may have had a skeletal x-ray survey done where x-rays of most of your bones were done and it took you a little while. Nowadays, we're starting to more often do other types of diagnostic imaging tests to look at the bones or other parts of the body, including CT scans, MRI scans, or PET scans. And I'm just going to go through some of these briefly. So here's an example of a patient with multiple myeloma who has had on the left-hand panel an X-ray. You can see the skull up top and then the bones in the spine of the neck below that. And then you start to get into the collarbones and the chest and the ribs. You don't get a great view. Sorry, I'm going to fix my video here. There. You don't get a great view of these bones in the spine on this X-ray. But then if you do a CT scan, which is a more sophisticated form of X-ray, you can get better pictures of the bones. And what you see here is the vertebrae, which is the stack of bones that forms the spine. The ones down lower here look how they should, kind of square. And then up higher, they're compressed. And that's because they have lost bone integrity. The bones are thin. Perhaps they've been damaged as there are tumors within them. And just under the weight of the skull and the brain and everything above, that those bones have been compressed. So those are called compression fractures of the spine. And they're, as you can see, much better seen here on the CT scan and on the X-ray. But sometimes you can see these things on a plain X-ray, and the X-rays are much quicker and easier to get done and easier to access. It takes less time. This is the same CT scan image moved over to the left-hand side, just to show it next to an MRI scan of the same patient on the right-hand panel. And you can appreciate that you get some additional anatomical detail from an MRI scan, which uses magnets to create the way the tissues in the body respond to a magnetic field can be used to generate these images. And you just now can appreciate that there's really a tumor within this vertebral body, this bone of the neck, and that some of that is extending outside of the bone and into this area behind the bones of the neck. So these are different ways to look at things. Here's an example of a PET scan. The way this works is people are injected with a small dose of radioactive sugar. The cancer cells take up the sugar very avidly. They like to take that up and use it. And so then areas of cancer will light up on a PET scan. This is an image showing on the left-hand side a CT scan of the pelvis of a patient with myeloma. On the right-hand panel is a PET scan of the same area. And then in the middle, the two images have been fused and the PET scan is colored with an orange scale to indicate the intensity of uptake of this sugar. So you can see this bone in the pelvis here, which actually has a fracture in it and is lighting up on the PET scan because there's myeloma cells in there causing that fracture. So those are some of the diagnostic imaging tools that we use to assess multiple myeloma. To really make the diagnosis, we need to get a sample of these plasma cells. And typically we do this with a needle. And we do something called a bone marrow aspirate or bone marrow biopsy. And those are both procedures that are done with a needle in a similar fashion to what's depicted here, where, for those of you who've had this done or have seen it done, you're lying on your side and probably one of your doctors is putting a needle, or sometimes it's the technician, putting a needle into the bone in the pelvis here to access the bone marrow, as you can see in the kind of magnified view down at the bottom. The needle is pushed through the hard cortex of the bone and into the spongy marrow. And then we can either core out a piece of that marrow with that needle, or we can withdraw some of that marrow into a syringe, as shown in the cartoon above. And then those specimens can be used in the hospital laboratory. They can be examined under the microscope and analyzed to look for multiple myeloma. Typically, myeloma patients will have at least 10% of their bone marrow occupied by myeloma plasma cells, if not a much higher percentage. So why do we need to do that? I mean, sometimes you get a scan and you see these bone tumors and you do the blood work and you see the monoclonal protein, and you pretty well already think you know what the diagnosis is. But to be sure, you've got to see those plasma cells and get a bone marrow biopsy or a biopsy of one of the tumors. Reason being, it's actually not all that uncommon for otherwise healthy individuals to have some of this monoclonal protein in their blood. This can be found in about 3% of people over the age of 50, and the likelihood of finding this increases with age from there. And most of those people don't have multiple myeloma. Most of them have something called MGUS, which some of you may know about, which stands for monoclonal gammopathy, that term that you heard earlier, of undetermined significance, which is just jargon for there's some monoclonal protein in the blood, but we don't know that there's necessarily anything wrong with that person otherwise. And so, you might find a bit of this protein in the blood in somebody who has some other bone disease causing the tumors in the bone, some other type of cancer, for example, or something else. So it's important to make the right diagnosis by getting a bone marrow aspirate and or biopsy done. An aspirate is just where they withdraw the marrow into a syringe, and a biopsy is where we core out a little piece of the marrow with the needle. We can learn also something about the expected behavior of the myeloma by obtaining some of those plasma cells and analyzing them and their genetic material. So the specific kinds of genetic abnormalities you see in the myeloma cells can predict something about the disease's behavior. And these are not necessarily or generally inherited abnormalities. These are just abnormalities that have been acquired by those plasma cells in the process of becoming cancer and becoming multiple myeloma. So these are not inherited genetic abnormalities. These are abnormalities only found in the cancer cells. And we can use a technique like this called fluorescent in situ hybridization, or FISH, to highlight the DNA in these cells and look for some of the common abnormalities that we see that help us understand the potential behavior of the disease. Nowadays, we're using DNA sequencing also to examine the genetic material in these cells in more detail and to get more information. This genetic information, as well as some of the blood tests, help us to decide what stage the myeloma is at. So what is cancer staging? Anyone who has cancer will hear about this term, cancer stage. So staging is a shorthand notation that health professionals use to tell each other quickly how much cancer there is in a patient's body, how widespread it is, and or how aggressive or risky the situation is with the cancer. This is a concept that might apply better to, say, something like breast cancer or prostate cancer, a cancer that typically starts in one part of the body and then, given time, without treatment, will spread in an orderly fashion to other parts of the body. So for those types of cancer, typically we talk about early stage cancers that are just confined to, say, the breast or the prostate, versus advanced cancers that have spread through the body. In the case of multiple myeloma, this is a condition that almost by definition is widespread at the time of diagnosis. You can occasionally see a plasma cell tumor that is apparently a single tumor just in one part of the body, and that's something we call a solitary plasmacytoma, which can eventually develop into multiple myeloma. But multiple myeloma is a widespread cancer throughout the body, particularly throughout the bones. You won't typically find it in the small bones like the hands and feet, but just about any other bone could have myeloma. So in the case of myeloma, staging looks at, markers of disease burden, we call it. So how many cancer cells are in the body? and markers of the biology of the disease, for example, using those FISH tests to look at the genetic material within the cancer cells. And from that, we can try and predict life expectancy to some degree, not very accurately for any individual patient, but for groups of patients, we can separate them into lower or higher stage groups. And this is the current staging system called the Revised International Staging System for Myeloma. There are 3 stages, and patients are categorized based on some blood test results. One is the serum albumin level. We talked about that, the most abundant normal protein in the blood. If people are sick, the albumin level tends to go down. So this is a marker of illness and disease burden. There's another test called beta-2 microglobulin. The level goes up the more myeloma is in the body. So higher levels of that suggest more myeloma. A blood test called LDH can also increase as the amount of myeloma in the body increases. So those are some of the blood tests that we use to determine the stage. We also look at some of the genetic markers in the plasma cells with that FISH analysis. And some of the markers we look at are listed here that suggest a more aggressive myeloma biology and perhaps a shorter life expectancy as a result. These are statistics from several years ago, indicating that patients with stage 1 myeloma have a likelihood of surviving 5 years from the time of diagnosis of about 80%. And then patients with stage 3 myeloma have a 5-year likelihood of survival of about 40%. Those numbers are better now than they were when this staging system was devised, but it gives you an idea of the staging of myeloma. And how did we pick these factors to put into the staging system? Well, basically people thought about the things that are associated with aggressive disease or a higher burden of disease and put them into a mathematical model and figured out which ones give the most predictive information. And that's how we came up with this system. So why do people get myeloma and who gets it? For any one person, it's usually hard to know. You do see some clustering in families, although no one has found sort of the gene for myeloma. So we can't usually say, here's the gene in your family, and we can't usually use genetics to predict who in a family might get myeloma. But most of the time, you don't see it running in a family, and you just see this happening in one family member. And why they have it is often hard to say. You see it a little more commonly in males than in females. You see it more commonly in African Canadians than in Caucasians. There are some occupations that some studies have suggested could be associated with a bit of an increase in the risk of getting myeloma, such as farmers who work with pesticides or firefighters who are exposed to smoke during their work. But most of the time, it's hard to know. Exposure to radiation, if someone's unlucky enough to have that problem, it could be part of the issue. We also know that myeloma is more common as we age. The average age at the time of diagnosis is around 70, although there's a wide range, and there's certainly lots of people younger than 70 who get diagnosed, but it's more common as we age. In Canada, we're expecting to see about 4,000 new cases this year, and the number of diagnoses each year in Canada has been increasing. I would say that number is about twice as high as it was 20 years ago, probably partly because there are more Canadians than there were 20 years ago, and partly because the baby boomers have been aging, and so there are more older Canadians than there were 20 years ago. But even accounting for those factors, it seems like there's more myeloma than there used to be. Whether we're diagnosing it more often or whether there's truly an increase in the number of cases people are getting can be hard to tease out. And if you look back, you can always find that someone had this MGUS condition we talked about earlier. People have always gone through a phase where they had a bit of this monoclonal protein in their blood, but did not have any signs of cancer. Now, not everyone has been aware that they've gone through that phase, but studies have shown that if you look back at stored blood samples on people who developed myeloma, that years prior to the diagnosis, you could find a bit of this protein in their blood. And people who have MGUS, or a bit of this protein in their blood, but no signs of cancer, go on to develop myeloma or a related disorder at the rate of about 1% each year. And, because these diagnoses are often made at an older age, and because other things can happen to people as we age, not, the lifetime risk is about 10%, because, not everyone with MGUS will live long enough to develop myeloma or related disorder. So one question that one could ask is, does everyone with myeloma need treatment? And not everyone does. There's a group of patients with myeloma who have too much there to call it MGUS, but not any active manifestations of myeloma, none of those crab features. Their bones are fine, their kidneys are fine, their blood counts are fine, calcium levels fine. But they've got lots of plasma cells in the bone marrow, or they've got a lot of this monoclonal protein in the blood. And people like that are called myeloma, their diagnosis is myeloma, but we don't necessarily treat them right away. But they have a higher risk of progressing to develop active myeloma than someone with MGUS. The risk is about 10% each year. And you can pick out from within those patients people who are at even higher risk based on the amount of myeloma protein in their blood or the amount of plasma cells in their bone marrow or other features. But people who have active myeloma, some of those crab features, or if they've just got a whole lot of myeloma in their body, even if they're not yet unwell from it, we need to treat that. And so you can think of this as a spectrum where you've got normal plasma cells that can turn into these MGUS plasma cells, a small clone of plasma cells that can then progress and multiply and progress to smoldering myeloma, where there's more myeloma there, but it's not causing any problems yet. And then progressing to symptomatic or active myeloma. And then sometimes later in the course of the disease to see myeloma cells in the blood or other organs, things like plasma cell leukemia. So there's a spectrum there. How do we treat myeloma? Well, it's a systemic disease, and primarily it requires systemic treatment. So treatments that can circulate through the body to where the cancer is. This is not a type of cancer that you can cure by removing it surgically. So we use drug treatments to try to control myeloma. And so we'll talk a bit about the different kinds of systemic therapy, including drug therapies and immune therapies and cell therapies. One of the more commonly used types of myeloma drugs are called immunomodulatory drugs, or IMiDs. These are typically analogs of the old drug called thalidomide, which has a notorious past, but has value in treating myeloma. Nowadays we use lenalidomide or pomalidomide, drugs that are similar to thalidomide, but have better, effectiveness and perhaps are better tolerated in some ways. There are newer such drugs in development. And these are typically administered as pills that you take by mouth. Some of our most effective myeloma drugs. We have proteasome inhibitors, a different type of myeloma drug, things like bortezomib, carfilzomib, ixazomib. Some of these are given by injection, either under the skin or intravenously, and some of these are given as a pill. We still use some old-fashioned chemotherapy drugs, including mostly cyclophosphamide and melphalan. Sometimes other traditional chemotherapy drugs are still used. We use steroids, dexamethasone, prednisone. For some reason, myeloma and some other kinds of cancer can respond to these drugs, which are used for many different things in different diseases. And these are typically given as pills as well. And these drugs are often given in combination. So then people have to contend with the side effects of these different types of drugs, either in combination or as they're used one after the other to treat their case. It's common for people to develop fatigue. Nausea is not uncommon. Occasionally vomiting, although it's not as big of an issue for myeloma treatment as it is for some other kinds of cancer treatment. These treatments can affect the gut. Sometimes people get diarrhea or constipation, depending on the patient and the drug. Rash is a not uncommon issue with some of these drugs. These drugs can affect the blood counts, just like myeloma can affect the blood counts, so we have to monitor those CBCs. These drugs can suppress those white blood cells in the immune system and make people more susceptible to infection. So we have to watch for that and deal with signs of infection promptly as they arise. People with myeloma and other cancers are prone to blood clots, typically in the deep veins of the legs. Sometimes those can travel to the lungs and cause problems. We sometimes take steps to put people on medication to prevent blood clots, especially when they're going on treatment, because treatment can further increase the risk. And if a blood clot develops, we sometimes need to put people on blood thinners for that. There's something called peripheral neuropathy, where the nerve endings in your fingers and toes can be damaged by some of these drugs, and you can get numbness and tingling or discomfort in those areas that can progress as your treatment progresses. People with myeloma and other kinds of cancer commonly complain about problems with memory, concentration, taking longer to figure out how to do something. Sometimes people call it chemo brain. But some of our other drugs that are not chemo can cause this feeling as well. It's not usually a severe issue, but certainly an annoying one to say the least. And sometimes it can be more severe. Those steroids are the ones often people complain about the most, the dexamethasone, the prednisone. There's a long list of side effects that maybe in the interest of time I won't go through in great detail, but suffice it to say that these need to be managed. Trouble sleeping, trouble with your mood. Blood sugars can go up, especially if you're already diabetic. Sometimes if you're not. You can get swollen, puffy in your legs, puffy in your face. Your skin can bruise easily. These medications can thin your bones, so that's an added problem when your bones are already challenged by the effects of your myeloma. And the list goes on. Some of you will have had stem cell transplants. So what this is, there's two different kinds. There's one called an autologous stem cell transplant. This is really just a way of getting a person through a high dose of chemotherapy, which is the part that treats the myeloma. But that high dose of chemotherapy can wipe out your healthy bone marrow as well, and that's where your blood is made. So before we give the high dose chemotherapy to a patient with myeloma, we'll collect what are called blood stem cells and put them in the freezer so that we can then thaw those out after the patient receives high dose chemotherapy, give them back to the patient through an intravenous line. Those blood stem cells will find their way into your bone marrow and start making blood again within a couple of weeks. And so this is basically an approach to giving people high dose chemotherapy and then dealing with the main side effect of that, which is to wipe out the blood producing system in the bone marrow. Patients often have to be admitted to the hospital for periods of time to do this treatment. But this intensive chemotherapy can add a couple of years to the average first remission with treatment. Not everybody's fit to do this. You know, if you're 83 years old and not feeling like you're 18 anymore, you probably aren't going to do this. So patients who are perhaps up to about the age of 70, perhaps a little bit older, if you're in really good general health, can undertake this type of treatment. So people go through phases where, you know, if you have myeloma and you're going to have high dose chemotherapy and an autologous stem cell transplant, first you might get some initial treatment with some of the drugs I've mentioned to get your myeloma under control. Then we'll mobilize and collect those stem cells from your blood that we can use to reconstitute your bone marrow after you get high dose chemo. Then we'll give you high dose of melphalan, Mel 200 we call it, and then give you back your stem cells so that you can start making blood again after we give you high dose chemotherapy. And then give some treatment after the high dose chemotherapy and the stem cell transplant to maintain the remission that you then find yourself in. Patients who are not eligible for a stem cell transplant for one reason or another will then receive continuous therapy with myeloma drugs that are not given at high doses, so that a stem cell transplant isn't required. And the approach up top there with the transplant is more intensive, but can lead to a longer remission than you might get without doing the transplant. But it's just not something everyone can do. This just indicates some of the drugs we use at each phase of the treatment nowadays. We'll come back to some of these drugs in a minute. Appreciate we might be running a little short on time, but I'm happy to stay longer if you are. There are other ways of doing stem cell transplants where you get your blood stem cells from a donor instead of using your own stem cells. This was the original idea of a bone marrow transplant, is to give a high dose of chemotherapy to wipe out the patient's bone marrow and then replace it with a healthy person's bone marrow to try to treat the cancer and maybe try and get rid of it. But what we figured out along the way is that the donor's stem cells will produce immune cells that can attack the myeloma, and that this is part of the therapeutic effect of a stem cell transplant from a donor, which is called an allogeneic stem cell transplant. This is a double-edged sword because those donor cells can also attack your healthy tissues, and this can be risky. So this is certainly also not for everyone and isn't really done that often, but it is done sometimes. And some people think that this might cure some patients with myeloma. I think that may be true, but it's also a little risky because there's a risk of not surviving the treatment. It's less risky to use your own stem cells and get the benefit of that high dose chemotherapy and then use other myeloma treatments to maintain your remission. So that's the more commonly used approach. Some of the newer treatments we have for myeloma are based on trying to harness our immune system to fight our cancer. So we talked about these antibody proteins. They're produced by myeloma cells. They're produced by healthy plasma cells. But antibody proteins can be designed to attack myeloma cells and used as myeloma drugs. So we talk about antibodies in different ways here. This is a cartoon showing an antibody called daratumumab attacking a myeloma protein called CD38 on the surface of a myeloma cell. So daratumumab is one of the drugs that we use as an antibody therapy for myeloma. Another drug called isatuximab also targets CD38 on the myeloma cells. And we try and pick targets on the myeloma cells that you won't find on too many other healthy cells in the body so that the treatment doesn't have a lot of off-target side effects. There's another one called elotuzumab that attacks a myeloma protein called SLAMF7 that isn't used as much in Canada, but is used occasionally. You can attach a chemotherapy drug to these antibodies and use this as a way of targeting chemotherapy drugs to myeloma cells. So here's a cartoon showing that if you attach chemotherapy drugs to one of these antibodies, that will then stick to the myeloma cell, and then that complex will get internalized into the myeloma cell, and then the chemotherapy drug will get released and kill the myeloma cell. So we've got a drug that we're using in Canada called Blenrep or belantamab mafodotin that targets a myeloma cell protein called BCMA. And that's how this treatment works. We have other kinds of antibody drugs that will work by trying to grab one of your healthy T cells, which is part of your immune system, and try and get that T cell to attack your myeloma cell. So so-called bispecific antibodies or bispecific T cell engaging therapies can do this, where one part of the drug brings the T cell in and activates it, and the other part of the drug attaches the T cell to the myeloma cell. And then you get that T cell firing on that myeloma cell and killing it. So these are treatments that are now in clinical trials and hopefully will become routine part of our myeloma treatment in the next few years. And so these are available to Canadians through clinical trials right now. There are other types of immune therapy, cell therapy. There's one called CAR T cell therapy, which involves taking T cells out of the patient's body and then genetically engineering them to attack those myeloma proteins like BCMA or other proteins on the myeloma cell. And so this is an expensive and complicated and resource-intensive therapy, but we're seeing really good progress with developing chimeric antigen receptor T cells or CAR T cells for myeloma patients. And hopefully in the coming few years, we'll start to see these being used more and more to treat myeloma. Right now in Canada, these are also basically mainly accessed through clinical trials. Aside from these systemic therapies like chemotherapy drugs or other drugs or cell therapies or immune therapies for myeloma, We do sometimes use what are called local therapies to treat one part of the body that's affected by myeloma. So surgery can be used to repair a damaged bone or to relieve the pressure that a tumor is putting on a critical organ like the spinal cord. Or we can shine high energy radiation, gamma rays at a tumor with radiation therapy. Myeloma is quite sensitive to radiation therapy, and so if there's a tumor in one part of your body that's causing you a lot of problems, a relatively low dose of radiation therapy can be quite effective and well tolerated to shrink that tumor and relieve the pain or whatever symptom or problem that tumor is causing. So these are certainly important parts of myeloma treatment. We do other supportive care therapies for myeloma. We'll give drugs to help strengthen the bones, things like Zometa or Aredia or Xgeva. We'll try and keep the blood cell counts up with transfusions or occasionally with medications. If the kidneys aren't working, sometimes we'll have to start dialysis to keep a person going if myeloma has caused kind of total kidney failure. And we'll manage pain with medications. We'll prevent or treat infection with medications or other therapies. And as I mentioned earlier, we'll use medications like aspirin or blood thinners to prevent or treat blood clots. So there's going to be a talk soon from Dr. Rees on myeloma research. And so I'm not going to dwell on this, but just to say that there is a lot of myeloma research happening in Canada, both in terms of clinical trials that are testing new therapies for myeloma patients. So participating in clinical trials is often a good way to get access to therapies years before they're otherwise available. And sometimes patients have really benefited from doing that. There's laboratory research on myeloma biology and treatment, where we use some of that blood and bone marrow that we obtain during the care of myeloma patients to study the disease and try and figure out better ways to monitor it, to manage it, to treat it. We have developed what we call real world evidence, where the outcomes of patients in Canada with myeloma is studied to determine how effective our current treatments are in the real world setting outside of clinical trials. And there are groups like the Canadian Myeloma Research Group and the Canadian Cancer Trials Group and other groups doing this research. The Terry Fox Research Institute is another supporter of laboratory myeloma research. So I'm just a couple minutes maybe over, but I'll stop there, and Charlotte can moderate question and answer session.
Yes, definitely. Well, thank you so much, Dr. Reiman, for sharing your expertise and insights with all of us today. So just a reminder, if you do have questions, use the Q&A box on your Zoom panel to type them in. Yeah, so we're not going to ask any like specific health ones, but we will follow up. A member of the community services team will follow up to try to answer or point you in the right direction for any unanswered questions. So let's see what has come in. Someone asked, what is considered a small increase, decrease? I think that's when you were talking about blood levels. Oh, and you are on mute. Sorry, Dr. Reiman.
Sorry, yeah, it depends a bit on which test you're looking at. If we're looking at the serum protein electrophoresis and measuring the M protein level on that, if the level goes up or down by 1 or 2 points, it's not necessarily a big deal. And sometimes from month to month, you'll see fluctuations up and down in that kind of range. So 1 or 2 grams per liter. But if you start to see 10 or 15 grams per liter changes, you might start to think, okay, this is more significant. If you're looking at the free light chain levels, then it maybe depends a little bit on what the free light chain level is. But if it's changing by, if it's doubling or if it's tripling or going up by more than a factor of 2 or 3, that's certainly significant. Sometimes less than that, it can be a bit hard to say whether it's really significant or whether it's just a fluctuation in the reading. But I think, in one patient, you might see that they have high levels of protein in their blood, and another patient might have lower levels. And sometimes a smaller fluctuation is more important in the patient with the lower levels. So it's all a bit relative. That's why it's probably best to try and interpret those results with your healthcare team on an individual basis.
Absolutely. Thank you so much. Okay, someone also asked, so when it comes to achieving remission, how does, a doctor determine when remission is achieved? And then I know we've gotten a lot of questions around remission versus like a cure. If you could maybe talk a little bit about sort of the distinction there.
Sure. Remission is not a precisely defined term, especially in the case of myeloma. What we use to assess how well treatment has worked is some internationally agreed upon what they call response criteria, or criteria for evaluating response to therapy. And this mainly relies on how much we've been able to see that myeloma protein level drop in response to treatment. And the lower that it drops, particularly relative to where it started, the better, because we know that the lower the protein level drops, that correlates with, how long we can expect that remission to be. Although the correlation is certainly not perfect. So, for example, a partial response to treatment is when the myeloma protein level on the electrophoresis goes down by 50%. A very good partial response is when it goes down by 90%. And a complete response is when it sort of disappears altogether. And there are other factors that go into it. How many bone marrow plasma cells persist after treatment? Are there any new signs of relapse in terms of bone lesions or high calcium levels? But remission, so, I would say that if you had a partial response, you could consider yourself to be in a partial remission. Complete remission is tricky because with myeloma, most of the time we don't expect to get rid of it completely. So we use the term complete remission or complete response when we can't see any myeloma protein in the blood and we can't really see myeloma in the bone marrow, but we expect there's still a little bit of hiding in there somewhere. Cure, it's a little early to talk about cure with myeloma in most cases. As I say, people who have an allogeneic stem cell transplant from a donor, we think maybe some of those people might be cured. But it's always hard to know because myeloma can relapse after many years of remission. People who have not had an allogeneic stem cell transplant, we can't yet really ever step forward and say we think we've cured your myeloma. We sort of expect it to relapse at some point, but excuse me. I mean, sometimes people can be in remission for 10, 15 years or more. And sometimes people will never experience a recurrence in their lifetime, even if, there might still be some myeloma hiding in their body. You might go skydiving and your chute doesn't open and you die of something else before your myeloma ever recurs. So sometimes people talk about functional cure or operational cure, meaning, okay, your myeloma went into remission that lasted the rest of your life, but you have to live out the rest of your life before you know if that's happened. So it's tough to talk about cure in myeloma yet, but certainly there's promise and hope that advances in therapy are going to eventually get us there.
Definitely. Well, thank you for clarifying that. Someone asked about the M protein. If the M protein doesn't serve our bodies, what does it do?
Well, as I say, normal healthy plasma cells that are not myeloma cells, produce antibodies that help us to do things like fight infection. But these myeloma cells, they've gone a bit haywire and they're replicating themselves in an uncontrolled fashion and they're growing into tumors and they're spreading through the body, but they still are programmed to produce antibodies. And that's that monoclonal protein or myeloma protein. But they're not doing so in response to an infection in that case. They're just doing so because those myeloma cells are growing in an unchecked fashion and continuing to produce antibody. So as far as we can tell, that isn't serving any useful purpose in the body, but it does serve a useful purpose at being a marker of the disease that we can follow, as we've discussed.
Perfect. Thank you for answering that. Let's see here. Someone asked about the bone damaged caused by the small myeloma tumors that you were talking about, can that damage be reversed, or is it something that an individual will always have to live with?
I think the short answer is that right now it seems a person's always going to have to live with that. I think bones can regain some strength and integrity with treatment, but I don't think they really regain the lion's share of their previous level of strength and integrity. So those damaged bones are always going to be a little bit fragile and need to be handled a bit with care. So, I always tell people, not to, who have significant bone damage from their myeloma, just be careful how much they lift, not to do things like jump off the bed of their pickup truck onto the ground. Sometimes people regret it when they go ride their four-wheeler ATVing in the woods on bumpy trails and are bouncing around for an hour. So you have to take a bit of care.
Definitely. Be gentle with yourself.
Yeah.
Let's see here. Someone asked about steroids. So he said that some patients can do away with taking steroids after lengthy periods of taking it. What's the criteria, I guess, for discontinuing steroids?
Right. It's always nice to be able to get rid of those steroids. And I think most of us feel like after a while, they might not be necessary for patients who have achieved a good remission. So for example, someone who's had high dose chemotherapy and is in remission, they're on a maintenance treatment with lenalidomide, for example, we don't routinely prescribe that person steroids and hope that they can stay in remission for many years without them. Someone who's relapsed after that and needs further treatment, or someone who's not been able to have high dose chemotherapy, and maybe the expected duration of remission from the current treatment is going to be shorter. Sometimes we're more inclined to err on the side of keeping the steroids going. But if with time it's apparent that the myeloma we've achieved a deep and durable response to treatment, and people are having ongoing problems being on the steroids, it's that case of weighing the pros and cons of being off them versus being on them, and deciding whether it might be in an individual person's favor to stop them, to relieve those side effects because their myeloma is under really good control. But I wouldn't say you could list a set of hard and fast criteria that'll apply strictly to each patient, because it depends a bit on how well the treatment's working on the one hand, and how many side effects from the steroid the person's having on the other hand. So you kind of have to weigh those things and make a decision with your doctor.
Definitely. Thank you so much for answering that. So I think we have time for two quick questions before we wrap up. So one person asked about why is there no treatment given for beginning stages to prevent the development into multiple myeloma? So I guess that's the smoldering myeloma or the MGUS.
Sure, we can start with that. So the thing about MGUS is that even if you determine that a person is at a higher than average risk of progressing to develop myeloma, the risk is still pretty low. Like a high risk myeloma, a high risk MGUS, still only has a likelihood of progressing to myeloma of, on the order of a few percentage points in a given year. And so for a lot of people, the downsides of the treatment that is currently available is likely to outweigh the benefits. And there will be a lot of people with MGUS that will never need treatment. Probably almost 90% of them will never go on to need myeloma treatment or any other kind of treatment related to their MGUS. For people with smoldering myeloma, it's an important question that we're looking at. And some people that we used to say have smoldering myeloma, we could identify factors that would predict a high likelihood of going on to develop CRAB features and active myeloma within the next 2 years. And so we now have reclassified some of those people who used to have a diagnosis of smoldering myeloma, and even though they don't have any symptoms or CRAB features, we say they have active myeloma. So there's a new acronym. Instead of CRAB, we talk about slim CRAB. So the S stands for at least 60% plasma cells in the bone marrow. The LI stands for a very high light chain level, free light chain level in the blood. And the M stands for MRI, evidence of focal bone lesions. And so some of those people, even though they have no symptoms of myeloma otherwise, will go on and get treatment before they develop any of those active features of the disease. We're still studying smoldering myeloma and trying to continue to identify those patients that are at high risk of progressing. And clinical trials are ongoing around the world to assess existing myeloma treatments to say, should we be giving them earlier if we can? So I think in the future, you'll see us treating more people, especially the more targeted the treatments get and the more effective they get and the fewer side effects they have, the more appealing it will be to treat patients at an earlier stage in the course of the disease. But we have to balance that against all the side effects and risks of the treatments themselves. And so it really needs to be, again, a risk-benefit analysis.
Definitely. And just to confirm too, those who are, diagnosed with MGUS or smoldering myeloma, they are, monitored by healthcare professionals.
Yes, so people with MGUS are often monitored by their family physicians, and sometimes they will see a specialist and get some advice about how to monitor that patient and make sure there's nothing going on that requires further investigation or treatment. But a family physician's office, or a primary care provider's office is a good place to have MGUS monitored a lot of the time. People with a higher risk MGUS or an unclear situation, or people with smoldering myeloma, those folks tend to get followed by a specialist more often.
Great, thank you so much for clarifying. All right, so last question. And just a reminder to everyone, if you didn't get your questions answered, we will follow up to make sure that we get you the information that you're looking for. So the last question is talking about bone marrow biopsies. Is it normally, always done after a diagnosis, and is it typically done just once and not used again to evaluate response therapy? So I guess how often can someone expect to get bone marrow biopsies done?
Right. Practice varies a little bit. At a minimum, everyone should have one at the time of diagnosis. And it's not uncommon that one will be done if it's not clear what the status of the disease is based on the blood work, to provide further information. It's sometimes helpful just to confirm, for example, that the myeloma is relapsing and requires a change in treatment by doing a bone marrow biopsy. Now, some of the research that we do involves doing bone marrow biopsies more often, so that we can study the biology of the disease over the trajectory of its care. And so, for example, this Cherry Fox multiple myeloma study that I mentioned briefly earlier, we're collecting blood and bone marrow samples at different points for research. Sometimes it's helpful when you're thinking about things like, should we go ahead and move on from the initial treatment to collecting the stem cells to do a bone marrow transplant? Because sometimes you're surprised, you do the blood work and you think the myeloma is responding to treatment, and then you look at the bone marrow and you see still there's a lot of plasma cells there, and you think, well, maybe we need to give some additional treatment first to get the disease under better control before we try to move on to the next stage of the treatment. So those are some examples as to how bone marrow biopsies are sometimes used over the course of time. Some patients have one bone marrow biopsy done at the beginning and then never really need another one because it's just fairly clear from other evidence what's going on. But those are some of the instances in which it's done again. And it is an uncomfortable procedure. I sort of look at it like going to the dentist. We put some freezing in, but you still feel some twinges when we're putting the freezing in. You still feel some twinges when we're doing it. But it doesn't take very long, and it can provide really valuable information. So if your myeloma doctor thinks it would be wise for you to have one now and again, then it's usually a good idea to just get her done. Much as we'd rather find a way to do without it. And eventually, I think new technologies will enable us to do fewer and fewer bone marrow examinations.
Thank you so much again, Dr. Reiman, for taking the time to be with us here today. I would like to remind, oh, sorry, if you can go to the next slide as we wrap it up. Perfect. So I'd like to remind everyone that we are here for you. Do not hesitate to contact us if you need more information or support concerning this topic or information on any of our programs and services. As you can see here, we have our contact information is listed on that slide. We have our email address. You can check out our website or you can give us a call toll free. A reminder too is we will have a second webcast on multiple myeloma research taking place tomorrow at, let me double check. I believe it's 1 p.m. Eastern. So you can still register for that on our website. Yes, 1 p.m. Eastern with Dr. Reese on myeloma research. So definitely check that out to learn more about that topic. Please note a short survey will be sent to all participants after this webcast. We greatly value and appreciate your feedback, and it really helps us, plan these sessions in the future. So if you don't mind taking a few minutes to fill it out, it will be greatly appreciated. And with that, again, thank you so much, Dr. Reiman, and thank you all for attending. I hope you have a nice rest of your day.
I'd just like to thank Leukemia and Lymphoma Society for inviting me to speak to you all today, and thank you all for attending. And I hope you found it worthwhile. And I'd like to hear that feedback as well, so I can, next time I do this, I can do even better.